We know you can check your PPT in the meantime.
Yes. Sir, the PPT will be displayed by you or should I share my screen? How is it?
No, no, you will be this thing, playing your this thing. You want us
Okay.
to play that?
No, 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 sir, I'll be doing.
You present like you present in your center.
Right. Is my screen visible, sir?
Yes, it will. It will. Good morning, madam.
Good morning.
I think Anu madam had joined and Dr. Ashish is also there. Dr. Kalai will take 5 minutes to join, so we can start.
Yeah, I'll also join, sir.
Okay, then we can start.
Good morning, respected faculty. I am Dr. Abhinav from Department of GI Surgery and Liver Transplant from AIMS New Delhi. Today, I'll be discussing on the operative critical steps and error prevention for proximal splenorenal shunt. So I'll be covering this surgery under few topics like steps from incision, retractor placement to opening the abdomen, entering the lesser sac, then the splenic artery ligation, followed by splenectomy, then splenic vein mobilization, exposure of the left renal vein, and the anastomosis. So uh, for positioning, if we are doing a Makuchi incision like in this, so for that we place the patient in supine position with a sandbag under her upper abdomen or the lower chest. Patient should be positioned at the kidney break area. Okay, her with the renal angle should be exposed so that when we do anastomosis, we can do a kidney break. Similarly, in few cases, we can do a thoracoabdominal incision like in the second photograph. Thoracoabdominal incision we rarely do now, but it was done some time back. This is the retractor, that Thompson retractor placement which has been done. It helps to retract the abdomen adequately. Now, after opening the abdomen, we have to see for any ascites, any liver abnormality, like if the patient has cirrhosis or not, nodularity is there, macronodular, micronodular, and the portal collaterals. If there is any enlarged left gastric vein or the massive left gastric collateral, or any unexpected pathology which could prevent us from doing the surgery.
Good morning, Abhinav. This is
Good
Dr.
morning, sir.
Hi, good morning. So before
Yes,
starting, can you give us some indications where this PSRS is indicated?
sure, sir. So PSRS, that is the proximal splenorenal shunt, is indicated in cases of like portal obstruction, portal venous obstruction. So patient may present with one hematemesis, which is a we say a bleeder. It could be a major bleeder or minor bleeder. In those cases, it becomes a kind of a secondary prophylaxis that we do a shunt and it helps to decompress the venous system. Second, we can do in cases with uh, venous obstruction, EHO presenting with jaundice. Jaundice that happens due to the portal bilopathy or portal cavernoma cholangiopathy. So in those cases, it is indicated. Thirdly, in massive spleen hypersplenism, patient presenting with recurrent pain or features of hypersplenism like epistaxis in female menorrhagia or early whether bruising. In those cases, we do PSRS. Thirdly, for primary prophylaxis, we could consider in patients with high risk varices, but they do not have access to hospitals very easily, like people living very far. So any bleed could cause a catastrophic or life-threatening bleed. So in those patients we provide surgery as a primary prophylaxis. These cases I discussed for EHPVO. In NCPF also for secondary.
नहीं नहीं मैं बंद कर दूंगा हाँ तो एक सॉरी
So in cases of NCPF also we can uh, provide them option for surgery as a secondary prophylaxis. In NCPF we try to avoid doing for primary prophylaxis because the outcome uh, is well, it's good, but the chances of complications is for a post shunt is also there. So for NCPF, we offer the surgery as a secondary prophylaxis.
So most commonly nowadays, PSRS is being done for EHPVOs
as a
with
major bleeder, sir.
major bleeder or mainly with other complications like biliopathy. Bleeds are being managed most commonly nowadays by endoscopy very well, no?
Yes, the bleeds are being managed with patients can be provided endotherapy, then they have to be on the beta blockers lifelong. So matlab in our center, sir, we offer them surgery for if they have blood and if they have required hospitalization or if they have required major blood transfusion. We provide them option for if they want to undergo a surgery or if they want to continue endotherapy or to be on beta blockers.
Okay,
Right, sir.
go ahead.
Abhinav, may
Yes,
I
good morning, ma'am.
again, good morning. Before going on to the operative procedure, I just wanted to say that as part of your preparation, is there
Right, ma'am.
like anything, and I'm not asking from the systemic like systemic preparation, from the point of view of operative technique,
Right, ma'am.
does imaging help you in any way? And are there any particular like things that you want to look for in imaging which will help you during your surgical procedure?
Yes, ma'am. Imaging is of a great help to us. So imaging for that we do a CT photography. Photography which we want to order dual phase. We want to see the venous system particularly. So in venous system, we start from the splenic vein. We want to see the caliber of the splenic vein both at the hilum or behind the pancreas at the midpoint. And we want to see the collaterals, the extent of thrombosis, if the portal vein is thrombosed, if the confluence is thrombosed, if the thrombus is extending to the splenic vein or not. Then we want to see the status of the SMV, if SMV is patent or not, in case we are not able to provide them the surgery for the PSRS. Then we have to see the uh, renal vein, renal vein and the lie of the renal vein, the caliber of the renal vein. And also we have to consider the anatomy and the status of the kidneys. If say if patient is having only a solitary single kidney, so it is not advisable to do a left PSRS shunt. So all these things has to be considered. Apart from this, the anatomy for planning for the surgery, also want to see the HPL area, the portal cavernoma cholangiopathy, the extent, if there is IHBRD or not, if there are stones or not, the strictures, what is the extent, all that has to be considered before planning a shunt. If the patient has presented with, say, let's say jaundice and he has undergone a multiple times ERCP stenting, in those cases, I would also like to consider doing a MRCP before uh, taking the patient on table. MRCP would help me to have some idea regarding if that the patient is having a teleopathy due to a compression from the portal vein or it is a ischemic stricture. So all these uh, things from the imaging helps us to plan the surgery well.
So basically, you are looking for a presence of a shuntable vein, especially the
Right,
splenic
ma'am.
vein. And as you
Yes,
said
ma'am.
about the kidney, but you said the lie of the renal vein. So is there any anatomical anomaly or something that about the renal vein which will affect your operative
Yes,
procedure?
ma'am. We in my residency, I have seen 2 to 3 cases of horseshoe kidneys. Also, the left renal vein, which generally uh, is have a straight line, it sometimes have a more diagonal line, so it helps us to find the renal vein in the right place, right direction
So,
actually.
so Abhinav, I would say that one thing, one of the important anatomical this thing is a retroaortic
Yes,
renal
sir.
vein.
But
That is
yes,
very important. You can very well see it, and if it is like that, then access to the renal vein will be a problem. So that is also an important thing. Okay.
right, sir.
Hmm. Yes, carry on, please.
Yeah,
So
just
after
before that, Abhinav, the incisions which you have mentioned.
right,
Uh,
sir.
so, I mean, you just call that as left makuchi, right?
Yes, sir.
Yeah, I mean, don't use the word because traditionally makuchi is for the right.
Right, sir. Left Makucha,
And
reverse Makuchi.
yeah, so also called as trapdoor. And then, so what is any advantages, proposed advantages with thoracoabdominal incision?
For thoracos, sir, in massive splenomegaly, we have found it difficult to mobilize the superior pole of the spleen and its division from the diaphragm and the retroperitoneal area and the posterior gastric area. So in cases like recently we have done in cases which patients have already undergone a surgery via chevron incision. So in those cases to have a separate plane, thoracoabdominal incision helps. Also, it helps in adequate mobilizing of the superior pole of the spleen.
Okay, yeah, please go.
So after doing a quick survey of the abdomen, we start entering the lesser sac. We divide the gastropolic ligament close to the gastroepiploic arcade while preserving the arcade of the gastroepiploic vessels and stay in the vascular plane. The stomach is retracted superiorly, transverse colon falls inferiorly, and the anterior surface of the pancreas is exposed. Like here, we are dividing the gastrosplenic ligament and ligating the short gastric veins, dividing it with energy. So with that, the anterior surface of the pancreas has been exposed. So we find and ligate the splenic artery. It is usually around the body of pancreas, and after opening the lesser sac, we have an easy exposure, and we do not have to lie it very proximally or very distally. The midpoint is the ideal area where we have to ligate it. So in that, the pitfalls are keep confusing the splenic artery with common hepatic artery. If we ligate it very proximally, there is a chance we find the common hepatic artery and we have a confirmation bias that we are ligating a artery, but we ligate the wrong artery. And excessive skeletonization has to be prevented because it can progress into a pseudoaneurysm also. Like here we can see the pancreas and the splenic artery is so we circumferential dissection is of utmost importance. We have to mobilize the artery adequately using bipolar anything, and we double ligate it. We do not have to divide the splenic artery. We double ligate it. After the ligation of the splenic artery, the congestion, the flow, the size of the spleen decreases. Also, some amount of decompression of the left system happens, and the we have an easy handling of the spleen. Now we progress to the mobilization of the spleen. So we divide the splenopolic ligament, the splenorenal ligament, gastrosplenic. Some surgeons try to were divided before going to the splenic mobilization, some do after. It all depends on their preference and their practice. And then the phrenicopolic attachment and the retroperitoneal. So here we can see the splenic adhesions has been released. We divide the splenopolic ligament and the retroperitoneal attachments. Use of energy device and bipolar wherever possible, wherever we are comfortable with can be done. In our center, we do most of the dissections with the ligashore and the bipolar. So what if we encounter a large collateral during a PSRS? So every collateral, they have a very fragile wall. They are a potential bleeder. So before dividing any collateral, we have to ask where it is draining. Can we preserve it, or does it interfere with our exposure? Is it feeding the operative veil? If these are not disturbing our train of dissection, it is better to avoid it. We do not need to divide the collaterals. But if it is coming in between, a small collaterals can be ligated safely and then divided. It is better to avoid ligating the large collaterals. After this, the splenic hilum has to
So,
be
so you just sorry to. So you mentioned about all the attachments. So
right, sir.
you divide all of them in the beginning?
Not in the beginning, sir. But the splenic, we have the splenic mobilization. I want to have the spleen control. So we start from the inferior pole. We have divide the splenocholic ligament from the inferior pole. Then I progress towards the left diaphragmatic area and the left retroperitoneal area. We progress from the lateral end. I go on to the uh, superior pole by dividing the control. Then with that, I then again start from the superior pole, and we try to have a adequate splenic mobilization so that I could have the spleen freely in our hand, so that we can progress to the hilum then.
Abhinav,
Right, ma'am.
how are these ligaments in EHPVO different from patients who do not have EHPVO? Is it like you just go on dividing these ligaments, like the way you have said? What is special about these ligaments in a
These
patient with EHPVO?
these ligaments have tiny collaterals. They have thick. Uh, that's it, and they are filled with collaterals in their blood. Other difference I have
So
not seen.
they are
Uh,
mostly heavily collateralized, right?
yes,
And
ma'am. Heavily
even the
collateral.
spleen, many a times in patients, you can have a lot of perisplenitis, very densely adherent
Right, ma'am.
spleen, right? So yes, as you said that we should not be entering the large collaterals, but while doing this surgical procedure, what will help you to achieve this? Like, how to dissect so that you don't enter the large ones.
We have to be closer to the spleen, ma'am. The plane of dissection has to be closer to the spleen. There, uh, there is some amount of avascular plane which is very close to the splenic capsule. We have to enter that area and be very careful with the gentle handling of the tissues and the collaterals, and we have to push it. The assistant do not have to give a shear tension. The assistant has to provide
Yeah.
adequate counter traction so that plane has to be visible very adequately, and then very safely in that plane we have to enter, and we keep dissecting it so that little by little the spleen exposes by itself. We do not have to force it. It exposes by itself, and then we have to mobilize it, and then we get a good control over it.
Yeah, and in an individual patient, the upper pole or the lower pole may be more difficult depending upon
Correct.
sometimes patients have very large varices, your patients have had glue and everything, so the upper pole will be difficult. So in an individual patient, you will have to see which is the easier one. So from the easy, you go to the more
Right.
difficult, and
More
you keep
difficult is
sweeping off these. If you stay in this plane, the larger collaterals will be swept off and you will not enter. Yeah.
right.
Suppose there is a bleed from some of the collaterals. So how would you approach those?
So if there is a bleed from a collateral, first of all, we have to clear the field. So clearing, I'll keep a gauge or a mop on the bleeding collaterals and apply suction. Ask the assistant to apply suction and clear the field of all the blood which is happening. Then slowly, I'll remove the gauge piece or the mop, and I'll see where the collaterals is, where the bleed is coming from. Compression on the collaterals helps to control the bleed for the some time. Then with good exposure, I'll apply a artery forceps or any clamp or anything. I like to hold the collateral which from where it is bleeding. After I have a control over it, and the area is clear, some spurt can be done. Then I'll ligate it safely. Uh,
Usually
uh,
these collaterals are big collaterals and with significant pressure and they bleed very massively. So in
it's
case there
yes,
is
sir.
a bleed which is significant, you control, you compress, and you immediately inform the anesthetist that there's a bleed. Probably I'm going to control this. But at present,
Right,
patient
sir.
is bleeding and he may bleed massively. So be careful.
Right, sir. Yes.
Okay, go ahead.
So after doing all that, we go to splenic hilum, and uh, there we tie uh, the polar vessels first close to the spleen one by one. When the polar vessels has been isolated and divided, we progress to divide the uh, splenic artery and the splenic vein close to the hilum. This has to be done close to the spleen to have an adequate length for doing the shunt in subsequently. So now coming to the mobilizing the splenic vein.
So,
So
just before proceeding, in a patient with previous multiple glue injections,
right, sir.
so while dividing the gastrosplenic and the short gastrics, so you will have a lot of challenges because the spleen will be densely adherent to the stomach there.
Yes, the greater curvature stuff is going
Yeah.
to be.
So, any technical modifications described to overcome that situation?
Uh, di- I'm not aware of any that is described, but what we do is we divide it basically the sometimes the serosa of the greater curvature is bared. So we progress and then we buddy or we take reinforcing sutures on the greater curvature of the stomach.
Yeah.
I'm
So
not.
the one technique which has been described and so we have done also is so in those patients, especially if they have the uh, residual or big gastric varices still not fully controlled, so you can actually add a fundectomy.
Right.
Yeah, so you can just use a stapler. So it helps in two ways. One is also helps to tackle the varices, fundal varices, and also makes that dissection also bit technically easier. It's a
Right.
described technique
Yes.
in those patients.
So
Right.
in mobilization of the spleen, actually, what all the madam and sir has said, like it is very important to go through a simpler area and to keep the like difficult areas for the later portion of your surgery. So you mobilize it all around, and then probably you'll be tackling. In case it is difficult to tackle this gastrosplenic area, that would be the last to tackle. And
Right, sir.
in that case, you probably have to have some window from both sides so that in case required, you can fire the stapler, or with clamping, you can divide and can control the bleed as well as the opening or injury to the stomach.
Yes.
Okay, continue.
So after doing that, we go on to mobilize the splenic vein. So here the goal is to have a long, healthy, and non-traumatized splenic vein with adequate mobility for the tension-free anastomosis. So the idea is to never dissect the vein. We dissect the tissues around the vein. We do not have to over-skeletonize it to the entirety of the splenic vein, and we ideally leave a thin cup of perivascular tissue around. So here the splenic vein mobilization, the pancreas has been held. The tissues around the splenic vein are dissected and ligated.
Before
Yeah,
removing the spleen, can we see the splenic vein and mobilize this posteriorly before removing the spleen and dissecting, like cutting it off from the hilum?
sir, it can be seen from the retrosplenic area. The generally the lie of the spleen vein is posterior to the pancreas. So when we have adequately mobilized the spleen and it has come in our hand, so the retroperitoneal retropancreatic area, we can see the uh, course of the splenic vein there, and from there we could do some amount of dissection so that the length of splenic vein is mobilized. But doing those uh, is I do not know if that is a good idea or not, because if that spleen is in our hand and if there is any injury to the splenic vein at that time, it is difficult to take a control there. And in that case, we will have to do a rush splenectomy by providing a clamp and then dividing it.
Why would
So,
there be injury in case actually every case is not the same? In
right,
different cases, you take different approaches. In case it is easily seen from behind, you dissect it. In case it is densely adhered to the tissues, probably you'll take out the spleen and you'll dissect it.
right, yes, yes, a splenic vein.
Abhinav, even if you are doing it like the way you are describing, that the spleen has been removed and now you want to mobilize the splenic vein,
Right,
will you just start mobilizing the vein? Is there any step in between where which you have to do before you can actually really start mobilizing the splenic vein from the pancreas? Because the vein is lying in the depths of your operative field, right?
yes, sir.
So how,
Like we,
you can lift the pancreas off and that's what you actually need to do before you can and you get a plane posterior to the splenic vein, which is actually the easiest. You can even see once the pancreas comes up, I think people have called that fascia also a name, that you can lift the pancreas off and then the posterior surface of the splenic vein becomes visible and you can start your dissection from there, because that is usually, there are no branches, like it is like there.
posteriorly,
So,
splenic vein
right?
does not have any
So,
branches.
yeah. So before you can start, actually, you have to lift the pancreas into your operative field more anteriorly, and you get to the posterior surface of the splenic vein, and you start
Yes, sir.
dissection from there, and then make your dissection circumferential.
Yes. So yes, sir, we do that. We generally after with splenectomy we have the whole of most of the pancreas lifted up already. But yes, pancreas has to be lifted up so that the posterior of the splenic vein, posterior surface of the pancreas is easily exposed, and splenic vein does not have any tributary posteriorly. So that vein is very good for the mobilization of the splenic vein. Otherwise, from the lateral, there are many pancreatic tributaries. Most are the small, thin, and fragile short tributaries. So pulling on the vein on these uh, can avulge the pancreatic tributaries flush to the vein. So if pancreatic injury happens, we end up with a hole on the splenic vein, or there is a bleed from the corners, it is difficult to see and difficult to control because the blood comes between the pancreas and the splenic vein, and it is difficult to control. So in those cases also we have to do improve the exposure, apply fingertip or sponge to the defect. We have to visualize the tear and repair it with the 5-6 Prolise sutures. So the question is how much veins should be mobilized? So enough to reach the left renal vein without tension, even after pancreas has fallen back into the natural position. So mobility has to be checked after releasing the retraction, and being that reaches only while pulling, it is too short. Okay? It should not be under tension. The idea is that. So what is if the splenic vein is too short and it reaches the renal vein under tension? The splenic vein has to be mobilized more medially, and additional pancreatic tributary has to be divided. And if the caliber is too small, the splenic vein can be spatulated and adequate renal venotomy has to be done. We avoid the purse string effect, and excellent intima to intima alignment has to be done. The idea is the flow matters more than the diameter. So here we can see the left renal vein and the splenic vein line. It is coming nicely without tension. Now coming to the left renal vein. The objective is to obtain a 3 to 4 centimeter freely mobile segment with the preserved venous drainage of the kidney. The mobility has to be suitable for the wide
तू
venotomy.
बोली कि मैं तो रेडी थी.
Sorry, sir. And allowing a tension-free, non-kink splenic vein anastomosis. The tributaries of the left renal vein, that is the adrenal vein, gonadal vein, and sometimes a posterior lumbar vein comes. So we could tie these tributaries to have a adequate uh, mobility and length of the left renal vein for the anastomosis.
Abhinav, where do you start looking for the renal vein? Like, how do you start? Because retroperitoneum, even after the spleen is out in these patients, is like, full of collaterals, very thick. There's chronic lymphatic obstruction. Where do you start looking for the renal vein? Where do you start your dissection?
I locate the superior and the inferior pole of the kidney, sir, and from that I get the idea of the hilum of the kidney, that is the midpoint. I palpate the renal artery pulse, and from that I uh, start dividing the retroperitoneal attachments to expose the left renal vein, and from there I go medially towards the IVC and the aorta, and with that area I get the exposure of the left renal vein, and going medially I could see more than the adrenal tributary and the left and the gonadal tributaries, and uh, we generally divide the gonadal tributaries. The adrenal tributaries can or cannot be divided on the caliber and the lie and how much it is disturbing our anastomosis. Then with that exposure I apply the clamp.
So is there like what is the arrangement at renal hilum? And sometimes is there any aberrations in that renal hilum that you should be careful about?
Generally, vein, artery, and the renal pelvis is the from the anteriorly. Vein comes first, then the artery, then the renal pelvis. Uh, the abnormality that
Many a
I'm
times
not
you find renal artery coursing anterior to the renal vein. So in that
right.
case, you loop the renal artery, and try to take it away from your dissection field.
Right.
Yeah, so I think the one important question which was so what you described.
Your
It
voice is
was,
breaking. I think.
yeah, I think that is it okay now?
Yes, yes, sir.
So the question which was asked regarding the identification of left renal vein. So what you described is one of the technique.
Right.
Sometimes a potential limitation would be we try to avoid also too much dissection in the retroperitoneum for identifying the left because sometimes when the collaterals are more, so that dissection itself per se can cause bleeding. So the other landmark is identify the DJ flexure and just go above it. So just remember when you are doing a ramps, uh,
Yes, sir.
and there are various approaches to approach the renal vein. So one of the approach is the infracolic approach, where we just mobilize the duodenojejunal flexure and then just superiorly above that you will get the renal vein. So that also is a good landmark, which means you don't have to identify the renal hilum, expose the superior inferior pole of the kidney. You can reach the renal vein directly, loop it, and then you can, depending upon the length of the renal vein to be exposed, you can go medially or laterally.
Yes. Right. So one rare thing happens is what if the lumbar vein, which is providing the supply to the left renal vein, it avulges while mobilizing the renal vein, and it generally immediately disappears behind the renal vein, and it continues as dark bleeding from the that area. So the idea is to release the traction and mobilize the renal vein more so that we could have adequate exposure to that area, and then find the lumbar stump which grasps with the forceps and then we ligate it. Now coming to the vascular anastomosis of the shunt. So before applying the clamps, we have to see and make sure, is the splenic vein long enough? Is there any twist in the line? Are all the tributaries divided if the renal vein is completely mobilized? Is there enough room to rotate the instrument, that is the clamps and the needle holder? And then generally in our center we give heparin to the patient according to the weight, 80, 80 mg per body weight, uh, and we wait for 3 minutes before applying the clamp. If all that is made sure, we go on to applying the clamp. The ideal clamp should be atraumatic and have enough length to control the vein, and it does not crush or slip. So here we can see applying the left renal clamp. Both U-shaped clamp and the Shatinsky can be applied. Here, both a bulldog or the in clamp. After applying the clamp, adequate venotomy has to be done. We keep Hep saline spurter in our hand between the. Now, venotomy should approximately match the diameter of the spatulated vein. Edges should be smooth, and any devitalized tissues has to be trimmed for the smooth anastomosis.
So
Suturing,
many a times, many a times you don't find supple splenic vein, although you have mobilized, but it is having like significant plaques. So what do you do in those situations? And what difficulties you will encounter if there is a plaque there, like significant calcified plaque in the splenic vein?
the suturing become difficult and it breaks. Intima separations can happen, and the chances of thrombosis also increases. So if the plaque is to the entire length of the splenic vein, then we have to be careful and do anastomosis with that area only. Or if it is from a tip, or if we could get above it with adequate length and the splenic vein is still reaching the anastomosis, the renal vein without tension, it can be divided or trimmed off. If it is so extensive that the lumen is compromised, or the caliber is very low, or chances of thrombosis, or it is not suitable for the shunt, then I'll ask the senior and check for other shunt, or we may abandon the shunt depending on the extent of the
Probably at that point of time, doing a shunt with careful technique would be adequate.
cancer.
Um, but their care has to be taken because it may leak continuously. The sutures may not hold, it may cut through. You should be very
Right, sir.
meticulous in that scenario. And in case it can be avoided, you will avoid with some trimming of further trimming of splenic vein.
Right, sir. Yes, sir.
Okay. Right.
Now coming to the suturing, we use a 6-of-proline. We take both the corners first. The knots has to come outside basically. The key is that posterior wall should completely be under vision, and we never have to sew blindly, and never use the sutures to pull the veins together. The veins should naturally meet, and sutures merely holds them together. So before completing the last stitch, we release the clamps. Common approach is briefly release the distal, that is the left renal clamp first, and flush the debris, any clotted uh, blood, air, or debris, and then reapply. Release the venous clamp, then release the splenic vein clamp, flush of every debris. And we inspect the suture line under gradually increasing pressure if it is all right. Confirm the flow and then complete the last stage with slight amount of growth factor. Here we can see the corners which has been taken.
So, Abhinav, say something about the growth factor. What is it and how do you ensure? Why do you need?
Generally, venous anastomosis, veins are expandable. It expands with the flow. So when we take sutures, that is a continuous sutures. So it is a, if we do not take a growth factor and we tie it there, the caliber which we have left is the final caliber, and vein the anastomosis does not have any area to expand further. But we have generally seen that the vein expands further. So taking a gross factor is the last knot which we are tying. One, 1 to 2 mm, the knot could be a air knot. So that first we take a 2 mm air knot, then subsequently all the knots comes over it. So that we give the vein the chance to expand further and then take its shape naturally. That is the good.
Yeah, go ahead.
And Abhinav, in whole of this procedure, you have not mentioned because it is routine practice at many centers to get the pressure measurement. In whole of the procedure, you didn't mention would you like to take some portal pressure in the beginning after splenectomy,
We
like
do not, yes, sir, we do not routinely do pressure with measurements, but in few cases, we have a thesis going on basically. We also have published a paper on the pressure measurements of the omental vein before before splenectomy, post splenectomy, and the post shunt. So, but it is described, and but we do not routinely do in every cases. But if we want to do a pressure measurement, we take a adequate omental vein, and we cannulate it with the pressure transducer with the help of the anesthesia team. And before ligating the splenic artery, we measure a first pressure of that is the baseline pressure of the from the omental vein. Then after ligating and doing the splenectomy, the second pressure has to be measured. And after completing the shunt, the third pressure has to be measured. And we have seen that the after completing the shunt, though it never comes to normal, but the idea of shunt is always to redistribute and decrease the pressure, not to bring it to the normal. So most of the time, almost always after completing the shunt, the pressure decreases significantly.
so you do not routinely measure this pressure?
Not not doing in every case, sir. In,
I think the question on the growth factor,
right.
so does it also, I mean, it's determined by are you completing the anastomosis with a single suture, or you're going to complete the posterior wall and you are going to use a separate suture for the anterior wall? Can you just elaborate on that?
Yes, sir. Growth factor is of a great help if we do all of the suturing with a single suture. We generally try to do with a single suture only. First, we come from the uh, from the posterior coming sutures. We take stays on both sides, but from the uh, one side we divide the stay and then we continue suturing with a single suture only. If we take a knot on the one side, one corner suture, then the point of growth factor decreases because then we have two knots. But still leaving a growth factor good gives some amount of expansibility to the anastomosis.
So, is there any, so you may mention 1 to 2 mm, right? Growth factor.
Right. 2 mm, yes,
So,
sir.
I mean, generally that's not the, generally that's not the way you calculate, right? Basically, it's a circumference. So obviously you don't measure the circumference. So you see the diameter of your anastomosis. Okay. And if you're going to use the single suture, then you leave actually the that much of a growth factor, ideally.
How much, sir? Diameter one.
Yeah. If you're going to complete the anastomosis with a single suture, you are not tying the posterior wall separately and the anterior wall. So the whole circumference has to be taken into consideration. And then we use the diameter. But the other technique is you keep the clamp on the renal vein, you release the clamp on the splenic vein, right? So
Right.
the kind of the anastomosis expands, and then you tie the last suture. So there you don't have to do this estimate how much growth factor I need to leave.
Oh,
Yeah,
okay, right.
actually, we also do it like this, that we release all the clamps, the anastomosis distends, we have a knot in place, we have not tightened it. So only
Yes, sir.
after it achieves its full distension, then you tighten. So
Yes,
already
sir.
the slack is taken by the flow. Like,
We also do, we remove all the clamps. The vein has already distended. Then we leave 2 mm, 1 to 2 mm, I think. Right. Okay. So after completing the anastomosis, what if we have a needle hole bleeding? So these bleeding are usually, it is harmless. We wait and we observe. The venous pressure often tamponates the small needle hole leaks. We do not place multiple unnecessary stitches for these small bleeds because every extra stitch increases the narrowing and it itself is an area of needle hole bleeding. So if there is a persistent bleed, we find the exact hole and we take one stitch, that is a 7-0 proline or the 6-0 proline, and that's it, nothing more.
Abhinav, what is this parachuting technique?
Uh, there's
The-
another technique of anastomosis, sir. Whenever that is the vein and the renal vein is not coming, if the exposure is not good, that is key, it does not meet naturally, it is not coming. Uh, because most probably because of the exposure, not because of the tension. So we keep it some place apart and we take continuous sutures from both the vein, splenic vein and the renal vein, splenic vein and the renal vein. And then finally, after completing the posterior wall sutures, slightly pull both of the ends slightly so that it would meet naturally. The advantages of the parachuting technique is that the exposure and the ease of taking the bites are easier because the field is larger. We could take each bite adequately and individually from the splenic vein and the left renal vein. After completing all the sutures adequately, we pull the both of the ends and the splenic vein and the left renal vein reaches medially, reaches meets beautifully. So this technique we do in cases when the exposure, that is the pancreatic tail is bulky and it is the exposure to meet the both of the veins are not adequate.
Yeah, actually, the every patient is different, so it may be
Right,
very
sir.
area where you are working in.
You're
But
right.
so in those cases, it may be very helpful, but you should be very cautious while handling a very thin, fragile vein. In that
Right,
case, it
sir.
may tear off like vein from the margin. Okay.
Yes, sir.
Okay.
So after completing the anastomosis, we check if there is any twist in, if the posterior wall is not caught behind the sutures, if there is any tension, or if there is a small hole. If we are not satisfied, if there is a posterior wall is taken, or if there is the flow is compromised, that is, we are not happy with the flow. In uh, extreme cases, we might have to take down the anastomosis and redo it. We do not, we never compromise with the flow. So the take home points from here is to never pull away, never chase bleeding, always expose it, do not accept tension, and flow is the king. Perfect looking anastomosis with poor flow will thrombus.
so Abhinav, I have a question. So
Yes,
you
ma'am.
finish your training in AIMS, you go to some independent setup, you are doing your first renal alone. and
Yes,
no seniors, and you have one resident who is new, doesn't know much about EHPVO. So you have to post this patient, and
yes.
you are a new consultant. Nursing staff also doesn't know. What what instructions will you give them before you start your surgery? What do you want arranged for you?
I'll brief them very detailedly, ma'am. First of all, I'll tell them to follow my instructions. Hear me very clearly.
What are
Second,
your instructions?
like, I'll ask them never suction blindly. Never give it.
I'm saying you're going to post this patient. Patient is not in the OT.
Okay.
What are your
Before
instructions to your resident and your nursing
regarding
staff? Yeah,
regarding the
before you
surgery.
start your surgery. See, this is often my beef with my residents. They all go to the OT. They are all ready to do the surgery, but operations begin before your incision.
Yes, ma'am.
So pre-operative orders are there. How will your resident prepare for the surgery? What all do you want him to do? Him or her?
Before that, I'll general pre-op instructions like part preparation, hydration.
You want them to arrange for some blood
Yes, ma'am.
audits? No, they will
Yes,
not
ma'am.
know if you don't instruct them.
Blood has to be adequate blood. 6 units of PRBC, 6 FFP, 6 RDP we arrange for the surgery. More blood has to the sample has to be kept in hand in cases if it is needed more. Cross match has to be made sure.
So you have to, when somebody doesn't know, you have to give them these ones. So
Mm,
arranging for blood, telling your anesthetist.
yes,
See,
yes,
you must have seen every time there is a new anesthetist, they see the platelets are 20,000.
yes,
They will
sir.
tell you
Yes,
arrange for SDP, arrange for
right,
RTP.
yes, sir.
Always it is there. They'll say many
Uh,
times their PT is like 1.5, 1.7. You must have seen many patients with EHP you have. And the anesthetist will say, arrange for fresh frozen, like they want FAP. So what I'm trying to say is, apart from the actual, before you start your surgery also, you have to keep all these things in your mind, and your nursing staff,
yes, sir.
what do you want them to know or arrange for you?
Arrange the adequate instruments,
What
clamp,
instruments?
clamps, the right
So you
clamp,
have to be specific. You have to tell them what vascular clamps you need, what sutures
yes,
you need,
switches
do
we
you need
need.
a graft, right? So all these
Yes,
things are very important part of preparing for your surgery, which I find that most residents actually think that these are not this thing. And the consultant has to come in. Many times you come and you say, okay, I don't have the Sitensky that I usually use because that instruction was not there. So these are also important parts. You should always see that your imaging is there on the view box, blood
yes,
is ready, your nursing staff knows, right? So all these are
yes, sir.
also very important parts of how you conduct your surgery, right?
Yes, sir. Thank you.
So in that context, you mentioned the advantages of arterial ligation first,
Yes, sir.
that it makes the spleen less congested, eases your surgery. Is there any other advantage?
It it increases the platelet if that is counted as an advantage.
So the gap between the arterial ligation
Mm,
and the venous ligation, what happens
mm.
during the time?
The splenic
Artery you have
in
ligated right
in
in the
in
beginning.
splenic inflow decreases and the hypersplenism decreases. The platelet count may
So
increase.
there are studies from your center only, how much
Yes,
hemoglobin
sir.
goes up, all the counts go up. So there's a lot of auto transfusion. Many times, if your surgical technique is all right and you have not had any surgical mishap, very rarely will you have to transfuse these patients despite their low counts and everything, right? You must have seen
Yes,
yourself.
sir.
You arrange for blood always because there is a chance that there may be a surgical mishap, but very, very rarely do you need to actually transfuse them, right?
Yes, sir. Yes, sir.
So you have finished the surgery. What is your post-operative instructions? What you will watch for in these patients?
In these patients, I'll have a close watch on the character of the drain. If the drain is hemorrhagic or the sanguineous, it will ring a bell. Other than that, the uh, I'll give the antibiotics and the analgesics basically. I'll have a post-op CBC to look for the hemoglobin. Generally, in post-op, we want hemoglobin around 7. That is enough. We do not want to over-transfuse the patient and increase the risk of the shunt. Yes, and that, uh, that's it, sir.
So
In
post-operative.
day, for day, I'll get a chest X-ray also.
Hmm. What is like acute gastric dilatation following splenectomy?
Acute gastritis is a rare phenomena, sir, where the stomach distends massively, and that because all the greater attachments has been divided, and it have a tendency to twist. So that is picked up easily on chest X-ray. So before removing a Rice tube, getting a chest X-ray is a good idea to rule out the acute gastric dilatation.
Usually not the chest X-ray. It's a rare phenomena, but that you should like keep in mind that may happen. So rise tube output, you may see for, and secondly, chest physiotherapy, adequate pain
Mm.
control for all these patients.
Yes, sir.
Watching the drain output, what is the character of it, and do you get amylase of this drain before taking it out routinely, or it is not the practice?
No, we do not do routine.
Okay, it depends on
If
volume
we
as well. Volume
volume,
correct.
if we have intraoperatively, we have a doubt that we have compromised this pancreatic parenchyma, then do, but routinely we do not. Or if there is a character comes out to be pancreatic, some amount of turbidity starts coming in the drink, then we do.
Okay. What is the protocol for antibiotic prophylaxis or antithrombotic prophylaxis? Is there any at your center, or it is not?
We have started a thesis, sir, on the giving the apixaban for and as a but it is not routinely done. It just have started. We have started a thesis. For antibiotic prophylaxis, we give augmented for 5 days, and generally we have a pre-splenectomy vaccination done. If not done, then post-splenectomy vaccination has to be
Okay. And one more thing, like post splenectomy, there's jump in platelet count that may go even with very, very high ranges. So is that a consideration? You want to see the CVC and platelet on what day, day 3, 4 or something? And if there is very high count, you would like to start something?
we do CVC alternate days, sir, on just post-op day, then the day 3, the day 5. If if something is off, that is sometimes the platelet count goes up to 10 lakh or something like that, more than 10 lakh. So still, we do not start anything with one reading. We look for the trend. Basically, sometimes one reading comes out more than 10 lakh, then it decreases. If it continues to be, I think, ecosprin or aspirin, we give generally for that increased but persistently high platelet count. But other than that, we do not chase the TLC or the platelet count in these cases.
Okay, you may not chase up to like 10 lakhs, but when platelet count goes beyond 10 lakh, usually people start at least ecosprin.
Yes, sir. Yes, sir.
I think we can ask for any doubts from others.
Yes.
That's right.
I think Dr. Bharti is there, Dr. Rajesh Panwar is there. Any comments from them?
Hello.
Yes, Rajesh. Anything
Dr.
you'd
Rajesh
like
here.
to come?
It was a very
Yeah.
nice discussion, sir. I just wanted to make 2 points. So, you may have a technique in mind, but you don't go with a rigid mindset in patients in whom you plan to do a shunt, because you might have to change course, because the first step that you think that you should be doing may be the most difficult step, and then you have to step aside and do another step and then come back to that step in the last. So you don't go with a rigid mind that I'll first do the splenic artery ligation only, then only I am going to proceed. So that is one thing. And the second point is that the surgery doesn't end with the shunt. So it has to be kept in mind that if you think the surgery is over with the shunt, then you will be re-exploring these patients in the night. So it is very, very important to ensure hemostasis after the shunt surgery. You have to ligate each and every ligament again, which you have divided maybe with a harmonic or a ligashore. So these are the potential sites of bleed. So these have to be underrun after your surgery, and then you have to ensure that the field is bone dry. Then only you can close these patients. So these are my 2 comments.
I agree. This point is extremely important. Like after splenectomy, before we even start with the shunt, hemostasis at that time, and careful hemostasis at the end of the surgery. Extremely, extremely important. I'm so glad you made this point.
Dr. Bharti, anything?
Good morning, sir. Can I make 2 comments?
Yes, sir, please.
Sir, this is Dr. Shaktivel from Shipma.
Yeah, please.
Sir, one thing is that regarding Madam told the preparedness for the anastomosis. Regarding that, like if you're in the news, starting the practice new, in the technical part, you should be orienting your assistant also regarding the venous anastomosis. Maybe you should tell them the vein anastomosis is very delicate. You should know what say your second assistant do, because you know the second assistant has to retract the stomach, has to retract the colon, everything, and he has to be stable at one point, and he has to do only with the forceps, he has to retract the vein wall and show the anastomosis. So that you should orient everything before, and the sister has to retract the colon down. So all these things should be pre-planned before starting your anastomosis. So what your second assistant do, what your first assistant should do, what your nurse should do, and start preparing your anastomosis with the fine sit-so properly. And take anastomosis, the tip of the vein. Don't take too much thickness of the vein wall. And the other thing is the clamp on the renal vein when you put, always make sure 2/3 of the renal vein wall is included in the clamp. Otherwise, if you miss on that step, if you include only 1/3, when you take the anastomosis, you won't be able to take a bite. And if the clamp suddenly moves a bit up, you won't be able to take the bite and you will miss the anastomosis. And the other point, like Saz stressed, after the anastomosis, we usually give heparin. And after heparin, we give a weight of, I mean, you can, after the anastomosis is over, after giving the growth factor, you can wait for 10 minutes, give a break, and then again wash and see whether the hemostasis is crystal clear. If not, make sure you bipolar, you organ, you take sutures, and make sure, because post-op also we have a practice of giving heparin for these patients. Those are the 2 comments I have to make.
I think very important point you raised. Assistance is very important in shunt surgery or any other surgery as well, but shunt is very important because without assistant, you can't do shunt, and he should be or she should be stable for at least 1 hour while you're doing that kind. Madam, can we summarize? Anu, madam?
Yes, Dr. Nag.
Yes, ma'am, yes. You can summarize or then
I think maybe it would be good for Abhinav after he has listened to everything. So what are the take-home messages, and then maybe we can.
Okay.
So, thank you for the take-home messages from my side is adequate preparedness for the shunt surgery is very important. The pre-operative planning is of utmost importance. That we have to know all the anatomy of all the vessels, everything, any abnormality is there or not before jumping onto the surgery. Everything has to be noted, has to be clearly communicated between the surgeons and the team involved. preparative blood blood cross matching, the blood availability has to be made sure. Then while doing these surgeries, we have to be very calm and we have to make sure that everything is in order. The uh, the planes has to be very clear. The exposure has to be very clear. Hemostasis has to be made sure before doing before proceeding on to shunt, after proceeding on to, after closing the abdomen. And then the uh, post-op care has to be. Yes, sir.
Yeah, so the operation includes both the pre-op, the intra, and the post-op. And intraoperatively, I think my residents never, I mean, they have to hear from me all the time, especially in portal hypertension surgery. Slow is fast. There is no hurry. Take your time. Stay in your proper planes. Take control. Like hemostasis at every step before proceeding, and doesn't matter. Ultimately, actually, you will spend less time if you are slow.
Please summarize, or other moderators can summarize and his performance and any messages for the residents. Then we can.
Nice presentation, Abhinav. You understood like what is the procedure, how do we proceed? But as you started with just incision and patient positioning. Okay. So pre-operative preparation and indications, where do we start? Like in case of any operative procedure you are asked for, you start with indications, what are the pre-operative preparations, and then you move to the like intraoperative steps. And then you mentioned all the intraoperative steps and you understood the procedure. It's okay. It's good. Yeah. Thanks.
Yeah, I think yes. So Abhinav, you've done well. I think the focus also has been to stick to the surgical steps, if I believe. So the key is any surgery, during each step, you need to understand what are the problems or the challenges you will encounter at each step. So once you understand that, then you will avoid that. I think that's key. So as you have rightly mentioned, in each step, what are the potential pitfalls? Because
Right.
it's important to understand that and then how you overcome that. So that's a key aspect of any surgery, especially more so in portal hypertension. So,
Yes.
very well done.
Madam, please. Madam.
Thank you, Dr. Nag. Yeah, I think everything has been nicely summarized. Good.
Okay.
Thank you.
I think his Anand's performance should be an inspiration and guide to the other resident. He was very calm in his presentation. He's taking pauses, never in hurry, and answering well. And wherever he have to take back and accept moderators' suggestions and comments and this thing, then he accepted well. I think that is a good thing. But overall, he has done well, and it was a nice presentation. And I think it would have helped so many residents and us also. Next presentation will be on 22nd, Saturday, 3 p.m. onwards by Jipmar Puducherry. Topic will be on post-operative ward round. Moderators will be Dr. N.R. Das, myself, and Dr. Rajesh Pandal. Thanks everybody, and thanks moderators and Avinu.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.